Everything you've been told about drugs, in school, from doctors, from the news, was filtered through politics, panic, and profit. Some of it is just embarrassing. Some of it is actively killing people. Here's the truth. 1. You've been told that marijuana is physically addictive like heroin, and that anyone who smokes regularly is basically one step away from a back alley needle. This comparison gets repeated so confidently, so often, that most people have never stopped to question the actual biology. Cannabis does not produce physical dependence the way opioids or alcohol do. There are no documented fatal cannabis withdrawal cases in medical history. Not one. Cannabis use disorder is real, but it involves psychological dependence, not the physiological withdrawal loop that makes quitting alcohol or opioids genuinely medically dangerous. Alcohol withdrawal can literally kill you through seizures. Cannabis withdrawal produces irritability, disrupted sleep, and appetite changes. Unpleasant, not life-threatening. Roughly 9% of people who try cannabis develop dependence, compared to 15% for alcohol, 17% for cocaine, and 32% for nicotine. The DSM-5 classifies cannabis use disorder separately from substances with severe physical dependence profiles, precisely because the underlying mechanisms are fundamentally different. And a significant portion of the cannabis is as addictive as heroin narrative was constructed during the 1930s reefer madness propaganda era, funded by interests with financial stakes in keeping hemp illegal, not by pharmacologists doing controlled research. Calling cannabis as addictive as heroin is like calling a parking ticket as dangerous as armed robbery. Same legal category on someone's spreadsheet. Completely different reality on the ground. 2. You've been told, through every after-school special, every DARE presentation, every panicked parent speech, that a bad enough cannabis experience ends in a body bag. The implication is always there. Use enough and it kills you directly. Here is the medical reality. No human being in recorded history has died from cannabis toxicity alone. The lethal dose is, for all practical purposes, pharmacologically unreachable by any human being trying. Studies estimate you would need to consume roughly 1,500 pounds of cannabis in under 15 minutes to reach a lethal threshold, a logistical impossibility that has never been approached, let alone achieved. The LD50, which is the dose required to kill 50% of a test population, requires quantities in animal studies so astronomically high that researchers consider them irrelevant to any real-world human exposure scenario. Deaths attributed to cannabis typically involve other substances, pre-existing cardiac conditions triggered by acute anxiety, or accidents that occurred while someone was impaired, not the drug shutting organs down. The CDC does not list cannabis toxicity as a standalone cause of death in its mortality data. Now compare that to acetaminophen, the Tylenol sitting in your medicine cabinet right now, which is responsible for approximately 500 deaths per year in the United States from overdose alone. That is a legal, over-the-counter drug people give their children without a second thought. You have a better statistical argument for fearing your multivitamin than fearing a fatal cannabis overdose. At least iron supplements have a confirmed body count. 3. You've been told that LSD stays in your spinal cord after you take it, sitting there dormant like a chemical time bomb, capable of releasing years later and triggering a spontaneous hallucination with no warning, no trigger, no context, just suddenly not present at your own sister's wedding. This is pharmacologically impossible, and it has always been pharmacologically impossible. LSD does not bioaccumulate anywhere in the body. It is fully metabolized and eliminated within hours of ingestion. Full stop. LSD has an elimination half-life of approximately 3.5 hours. The body processes and excretes it within 24 hours of a dose. No credible toxicological study has ever detected LSD stored in spinal cord tissue, because the spinal cord is not a drug storage facility. It is part of your central nervous system, and it does not work that way. The myth most likely originates from a real but rare and completely different condition called HPPD, hallucinogen persisting perception disorder, which involves persistent visual disturbances in a small number of psychedelic users. But HPPD is a neurological condition involving changes in visual cortex processing, not residual chemical releasing from a vertebra. It affects an estimated 1 in 50,000 users. The Stored in the Spine story was actively promoted by anti-drug campaigns in the 1970s and 80s as a deterrent, with no scientific basis ever provided, never peer-reviewed, never demonstrated in any laboratory setting. Your spine is not a drug storage unit. Telling people LSD lives in their vertebrae, waiting to ambush them, is the pharmacological equivalent of telling a kid their face will freeze that way. Effective scare tactic. Zero biology. 4. You've been told that heroin was invented in criminal laboratories, cooked up in the shadows by people who wanted to destroy lives. That it was always understood to be a dangerous street drug, something that existed outside of medicine and civilization from the very beginning. The actual history is considerably more embarrassing for everyone involved. Heroin was invented by a major pharmaceutical corporation. It was marketed globally as a cough suppressant for children. It was explicitly branded as non-addictive by the company that manufactured it. Bayer AG, the same company that makes the aspirin in your medicine cabinet, synthesized diacetylmorphine in 1898 and trademarked the name heroin, derived from the German word heroisch, meaning heroic. Bayer marketed it as a safe, non-addictive substitute for morphine, including for pediatric use, and sold it over the counter in pharmacies across Europe and the United States. The American Medical Association endorsed heroin for medical use in 1906. It took over a decade of widespread, documented addiction before it was finally brought under legal control. The Harrison Narcotics Tax Act of 1914 began its restriction in the U.S. The most feared drug on the street was once a branded pharmaceutical product with a corporate logo on the box, recommended by doctors for your child's cough. The lesson here is not that heroin is misunderstood. The lesson is that the words approved and safe have never, at any point in history, meant the same thing. 5. You've been told that cocaine exists exclusively as a criminal product, something that has always lived in the shadows, always been illegal, always been unambiguously understood as a destroyer of lives. The timeline on that is off by several decades and several papal endorsements. Coca-Cola's original 1886 formula contained cocaine from coca leaf extract. The name literally references it. Sigmund Freud published a paper in 1884 called Über Coca, enthusiastically recommending cocaine as a treatment for depression, morphine addiction, and fatigue. A cocaine-infused wine called Vin Mariani was so well regarded that Pope Leo III gave it a commemorative gold medal. Queen Victoria consumed it. President Ulysses S. Grant drank it. Cocaine was also used as a topical anesthetic in early surgical procedures and remains the only naturally occurring local anesthetic. It is still technically used in certain ENT surgeries today. It was not federally restricted in the United States until the Harrison Narcotics Tax Act of 1914, and even then, the primary political driver was not a newly discovered pharmacological danger. It was a racialized moral panic that targeted Black Americans in the South, with newspapers running fabricated stories about cocaine giving Black men superhuman strength and criminal impulses. The Pope had a commemorative medal for the cocaine wine. The president drank it. The most famous psychologist of the era prescribed it to patients. You are not living in a world that figured out drugs were dangerous. You are living in one that periodically decides which dangerous things are socially acceptable. That decision has never been made by pharmacologists. 6. You've been told, and shown, that MDMA makes holes in your brain. The defining image of 1990's anti-ecstasy campaigns was a brain scan displaying devastating dark voids, presented as proof that a single pill was consuming your gray matter like acid through wet paper. That image was fraudulent, The researcher who produced it admitted the comparison was false, and MDMA is currently in FDA clinical trials as a therapy for post-traumatic stress disorder. In 2002, Dr. George Ricorte published a study in the journal Science claiming MDMA caused severe brain damage. The paper was retracted in 2003 after it emerged that the primates in the study had been accidentally injected with methamphetamine, not MDMA, the wrong drug. The holes in the brain images shown in anti-drug campaigns were PET scans comparing heavy, polysubstance drug users to sober individuals. The dark areas represent regions of lower metabolic activity, not literal anatomical voids in brain tissue. The FDA granted MDMA-assisted psychotherapy breakthrough therapy designation in 2017 for PTSD treatment. Phase 3 clinical trials showed approximately 67% of PTSD patients who received MDMA-assisted therapy no longer met PTSD diagnostic criteria after treatment. The government showed you fabricated brain damage images for 30 years. Now, the same regulatory body is approving the drug as a treatment for the psychological wounds of combat veterans and trauma survivors. The holes in the story are significantly larger than any holes that ever appeared in the brain scan. 7. You've been told that methamphetamine and your ADHD medication are completely different things. That one belongs to the category of medicine, and one belongs to the category of societal collapse, and never the twain shall meet. Methamphetamine is an FDA-approved medication. It is prescribed for ADHD and obesity. It is called Desoxyn. You can pick it up at a pharmacy with a valid prescription. Desoxyn, methamphetamine hydrochloride, has been FDA-approved since 1943 and remains a Schedule II controlled substance available by prescription today. Adderall, the most commonly prescribed ADHD medication in the United States, contains amphetamine salts, one chemical step below methamphetamine, with virtually identical mechanisms of action in the brain. Both work primarily by flooding the synaptic space with dopamine and norepinephrine and blocking their reuptake. The distinction between prescription stimulants and street methamphetamine is primarily one of dose, purity, administration route, and regulatory oversight, not fundamental pharmacology. Approximately 6.1 million children in the United States are diagnosed with ADHD, making stimulant medications among the most commonly prescribed drug classes in pediatric medicine. The chemical your government classified as the face of societal ruin is prescribed to children every morning before school. The difference between medicine and poison has always been the label on the bottle, the dose in the pill, and who signed the permission slip. That distinction matters enormously in practice. It has never been a distinction in pharmacology. 8, you've been told, by culture, by policy, by the framing of virtually every addiction story you've ever seen, that addiction is ultimately a choice. A weak person's choice, a bad person's choice. A moral failure dressed in medical language for political convenience. Addiction is classified by every major medical authority on the planet as a chronic brain disease involving measurable, documented neurological changes, and it has about as much to do with moral character as type 2 diabetes does. The American Society of Addiction Medicine, the American Medical Association, and the World Health Organization all classify substance use disorder as a brain disease. Chronic drug use physically alters the prefrontal cortex, which governs decision-making and impulse control. It alters the nucleus accumbens, which is your brain's reward center. It alters the amygdala, which regulates stress and emotional response. These structural brain changes are visible on neuroimaging, are comparable to changes seen in other recognized neurological diseases, and do not require a moral failing to produce. Genetic factors account for approximately 40 to 60% of an individual's vulnerability to addiction, according to the National Institute on Drug Abuse. The moral model of addiction was not replaced by the disease model because society became soft. It was replaced because treatment outcomes are dramatically better when the disease framework guides clinical intervention. Telling someone to just stop being addicted works about as well as telling a diabetic to just decide to produce insulin. The biology does not care about your opinion of the person's character. It just keeps running the same broken loop. 9. You've been told that marijuana is the door. Walk through it, and you are on a conveyor belt. One joint leading inevitably to harder substances. The progression almost automatic. The destination essentially predetermined. This was the cornerstone of drug education for 4 decades, and it has been systematically dismantled by research. The Institute of Medicine's 1999 report, commissioned by the White House, concluded there was no evidence that cannabis use itself caused progression to harder drug use. The vast majority of cannabis users, over 90%, never use heroin or cocaine at any point in their lives. The statistical correlation the gateway theory relies on is a textbook case of confusing correlation with causation. People who seek out one illicit substance often share underlying risk factors: genetics, trauma, mental health conditions, social environment, that predispose them to substance use broadly. Cannabis does not create those risk factors. It simply gets used first because it is the most widely available illicit substance. Alcohol and tobacco are statistically stronger predictors of subsequent harder drug use than cannabis, yet neither is described as a gateway drug in public policy because the political narrative requires a specific villain. A 2010 study in the Journal of Health and Social Behavior found socioeconomic factors predicted drug escalation far more reliably than prior cannabis use. By gateway logic, everyone who ever tried heroin also drank milk as a child. Milk is not the gateway. The door was already open before they ever touched the cannabis. Cannabis just happened to be standing near it when someone took the picture. 10. You've been told that making overdose reversal medication freely available encourages more drug use, that giving people a safety net removes consequences, and therefore promotes reckless behavior. Saving lives, the argument goes, is an enabler. This is not a medical argument. It is a punishment philosophy dressed in public health language, and the actual research has repeatedly failed to support it. Multiple peer-reviewed studies across multiple countries have found no evidence that naloxone availability increases drug use rates. It just prevents deaths. A 2016 study in the Annals of Internal Medicine found that communities with expanded naloxone access showed no increase in drug use rates. A 2019 study in Health Affairs examined 30 U.S. states and found naloxone distribution programs were not associated with increased opioid use at the population level. Naloxone has no abuse potential whatsoever. It produces no euphoria, no high, and is of zero interest to anyone who is not actively overdosing on opioids. The CDC estimates naloxone has reversed over 1 million overdoses in the United States since tracking began. Countries with the most aggressive naloxone distribution programs, including Portugal and Scotland, have simultaneously implemented comprehensive drug policy reforms and seen reductions in overall drug-related harm. No one has ever argued that putting seatbelts in cars encourages reckless driving. The logic that a life-saving tool causes the problem it prevents is not pharmacology. It is not epidemiology. It is a moral position that has been assigned a body count. 11. You've been told that psychedelics cause permanent insanity, that there is a threshold beyond which the mind simply does not return, and that people who crossed it are wandering somewhere unreachable, permanently disconnected from reality by a single bad trip. After decades of research, the actual data does not support the permanent insanity narrative, and the risk factors for the rare adverse outcomes are now well documented. A 2015 study published in the Journal of Psychopharmacology analyzed data from over 130,000 people and found that psychedelic use was not associated with increased rates of mental health problems in the general population. The greatest documented risk factor for psychedelic precipitated psychosis is a pre-existing personal or family history of schizophrenia or bipolar disorder, a known contraindication that is standard screening procedure in every legitimate clinical setting. Psilocybin, LSD, and mescaline are non-neurotoxic at typical doses. They do not kill brain cells. Johns Hopkins and NYU have both conducted multiple clinical trials with psilocybin, accumulating hundreds of supervised sessions with no documented cases of lasting psychotic breaks in properly screened participants. HPPD, the actual persistent condition, sometimes seen in heavy psychedelic users, is a visual cortex processing disorder, not psychosis, and is relatively rare even among frequent users. The permanent insanity myth kept millions of people away from substances that research now shows can reduce depression in terminal cancer patients in a single session. The insanity was always in the policy, not the pharmacology. 12. You've been told that any use of an illegal substance is automatically equivalent to abuse, that the mere act of consumption, regardless of context, frequency, or functional outcome, represents a problem requiring intervention, a crisis requiring a response. This framework treats use and disorder as synonyms. They are not. The majority of people who use controlled substances do so without developing dependence, without significant health consequences, and without any meaningful impairment to their daily lives. NIDA data shows approximately 10% of people who try an illicit substance will develop a use disorder. That means roughly 90% do not. The DSM-5 requires that substance use cause clinically significant impairment or distress to qualify as a disorder. Use alone is not a diagnostic criterion and has never been one. Harm reduction frameworks, endorsed by the World Health Organization and public health organizations globally, explicitly distinguish between use, misuse, and disorder, because conflating them produces worse health outcomes, not better ones. Historical and anthropological evidence shows controlled, ritualized, or recreational use of psychoactive substances is documented in virtually every human culture across all of recorded history. The Any Use is Abuse framework emerged primarily from mid-20th century American political drug policy, not from clinical observation, pharmacological research, or public health epidemiology. By the logic that all use is abuse, every person who has ever had a glass of wine with dinner is an alcoholic. The problem has never been the substance existing. The problem has always been the relationship with it. Those are not the same conversation, and treating them as identical has caused significant harm. 13. You've been told that there is a clean, reliable shortcut to understanding drug safety. Legal equals safe. Illegal equals dangerous. If a doctor prescribed it and a pharmacy dispensed it, it belongs to the category of things that help you. If it is sold elsewhere, it belongs to the category of things that destroy you. Legal status has never been a reliable proxy for pharmacological safety, and the historical record on this point is extensive enough to be embarrassing. Prescription opioids, OxyContin, Vicodin, Percocet, have killed over 500,000 Americans since 1999 in what the CDC designates the opioid overdose epidemic, all from legally manufactured, physician-prescribed, pharmacy-dispensed medications. Thalidomide was a legal, doctor-prescribed sedative that caused severe birth defects in over 10,000 children globally before being withdrawn in the 1960s. Benzodiazepines, Xanax, Valium, Klonopin are legal, widely prescribed, and produce one of the most medically dangerous withdrawal syndromes of any known substance, comparable to alcohol and potentially fatal if stopped abruptly. The pharmaceutical approval process reduces risk. It does not eliminate it, and post-market surveillance routinely reveals dangers that pre-approval trials completely missed. Meanwhile, psilocybin and LSD, both Schedule I substances with no recognized medical use under federal law, are currently producing significant, replicated clinical evidence of therapeutic benefit across multiple major research institutions. A signature from a physician and a child-proof cap are administrative steps. They have never been pharmacological guarantees. 500,000 body bags in 30 years should have been the clue. 14. You've been told that overdose is simple arithmetic. Person took too much. body shut down, and the solution is therefore obvious. Take less, or nothing at all. This model misses one of the most documented and lethal mechanisms of opioid overdose death, which has nothing to do with unusually high doses and everything to do with what happens to the body after a period of abstinence. Opioid tolerance drops dramatically within days of stopping use. A dose that was completely routine before a period of sobriety can become lethal afterward, because the body's adapted tolerance is gone while the psychological pull toward the familiar dose remains. This is why overdose risk is statistically highest in the 30 days immediately following release from incarceration, discharge from detox programs, or departure from residential treatment, all periods of forced abstinence. A landmark study published in the BMJ found that recently released prisoners had overdose mortality rates 12.7 times higher than the general population in the 2 weeks following release. Fentanyl contamination of the illicit drug supply adds another layer. Users take what they believe is a familiar dose of a familiar substance that has unknowingly been cut with something dramatically more potent, and the arithmetic of too much becomes irrelevant to the outcome. Environmental cues, returning to a location associated with prior use, can themselves trigger tolerance reduction, a well-documented pharmacological phenomenon. The deadliest moment in opioid addiction is often not the deepest point of use. It is frequently the period right after someone sincerely tries to stop. 15. You've been told you can spot a drug user by looking at them. The gaunt face, the deteriorated appearance, the obvious unraveling. The stereotype is so ingrained that if someone holds a job, maintains a home, and shows up to family events looking functional, they simply do not fit the profile. And the assumption is they do not have a problem. The majority of people with substance use disorders are functionally employed and outwardly indistinguishable from anyone else. The visual stereotype describes a late-stage minority of cases, not the typical presentation of the condition. SAMHSA data shows approximately 75% of people with substance use disorders are employed. High-functioning addiction is documented extensively in clinical literature. High-achieving professionals in law, medicine, and finance are significantly overrepresented in certain substance use disorder populations, not because those professions cause addiction, but because access, stress, and cultural norms intersect in specific ways. Alcohol use disorder alone affects approximately 14.5 million Americans, most of whom hold jobs, maintain families, and are socially invisible as people with a diagnosable condition. The visual deterioration associated with addiction is the result of years of untreated disorder intersecting with poverty, healthcare barriers, and lack of social support, not the initial presentation of someone who started using 6 months ago. Physicians, nurses, and pharmacists have documented substance use disorder rates 10 to 15% higher than the general population. The person who does not look like an addict is statistically the most common kind. You have met dozens of them. The stereotype does not fail because it is unkind. It fails because it is inaccurate, and inaccuracy costs lives. 16. You've been told that cold turkey carries a kind of moral prestige, that stopping completely and immediately is the respectable path, the willpower path, the proof that someone is serious about change. For several substances, abrupt cessation without medical supervision is not a dramatic act of resolve. It is a medical emergency waiting to happen, and for 2 specific drug classes, it can kill you. Alcohol withdrawal syndrome can progress to delirium tremens, a condition involving seizures, hallucinations, and cardiovascular collapse with a mortality rate of up to 15% if untreated and unmanaged. Benzodiazepine withdrawal produces a clinically equivalent seizure risk and is considered medically comparable in danger to alcohol withdrawal. Opioid withdrawal, while described by virtually everyone who has experienced it as genuinely agonizing, is rarely directly fatal in otherwise healthy adults. But the associated dehydration, dangerous vomiting, and near certain return to use with dramatically lowered tolerance make it extremely dangerous without supervision. Medically supervised withdrawal management reduces mortality risk for alcohol and benzodiazepine dependence substantially. The cold turkey mythology around opioids in particular has contributed to policies of abrupt prescription discontinuation that drive patients directly to the unregulated illicit supply where fentanyl is waiting. Just stop is fine advice for a bad habit. For alcohol or benzodiazepine physical dependence, it is advice that ends in a coroner's report with some regularity. The dramatic, willpower-driven Hollywood quit is one of the most selectively lethal things popular culture has ever managed to normalize without anyone noticing. 17. You've been told that the federal government's classification of cannabis as a Schedule wine substance, alongside heroin, with no accepted medical use and high abuse potential, reflects the settled scientific consensus on whether cannabis has therapeutic value. It does not reflect science. It reflects a 1970 political decision that has been contradicted by clinical evidence for decades. The FDA has approved 3 cannabis-derived medications: Epidiolex, which is cannabidiol for epilepsy; Marinol, which is synthetic THC for chemotherapy-induced nausea and appetite loss; and Syndros, also synthetic THC for the same indications. 38 U.S. states had active medical cannabis programs as of 2024, all operating on legislative findings that cannabis has documented medical utility, which is a direct legal contradiction of its federal Schedule I status. A 2017 National Academies of Sciences report reviewed over 10,000 studies and found conclusive evidence that cannabis is effective for treating chronic pain, chemotherapy-induced nausea, and spasticity in multiple sclerosis. The DEA's own administrative law judge ruled in 1988 that cannabis was one of the safest, therapeutically active substances known and should be rescheduled. The DEA overruled its own judge. The federal government simultaneously holds patent number 6,630,507 on cannabinoids as neuroprotectants while classifying the plant as having no medical value. They are arguing both sides of the same case at the same time. That is not a scientific position. It is an administrative one that has outlasted its political justification by about 4 decades. 18. You've been told that the central fear of drug policy reform is solid. Remove the legal prohibition, and everyone will start using. The floodgates open. Use rates skyrocket. The enforcement is the dam, and without it, the water rushes in. The available evidence from real-world decriminalization and legalization experiments across multiple countries and U.S. states does not support this prediction. Portugal decriminalized personal possession of all drugs in 2001. Drug-related deaths fell from 80 per million to 3 per million by 2017, and drug use rates remained below the European average. Following cannabis legalization in Colorado and Washington in 2012, teen cannabis use rates, the demographic prohibition was ostensibly protecting, did not significantly increase, and in some measures declined. The Netherlands has had de facto cannabis decriminalization for decades, and its use rates are consistently below those of countries with strict prohibition, including the United States. Alcohol prohibition in the United States from 1920 to 1933 did not reduce alcohol-related harm. It transferred the supply chain to organized crime, created dramatically more dangerous unregulated products, and ultimately failed to meaningfully reduce consumption. The most predictive factors for substance use disorder rates in a population are poverty, trauma, and lack of healthcare access, not the legal status of the substance. The fear that removing a law makes a behavior explode assumes criminal penalties are what stops most people from doing things. Most people who do not use heroin are not abstaining because they reviewed the sentencing guidelines. The law was never the primary barrier. It was just the most visible one. 19. You've been told that medication-assisted treatment for opioid use disorder is just trading one drug for another. That people on methadone or buprenorphine are not really in recovery, just differently dependent, and that real recovery means no substances at all. This philosophical position, applied to medicine, has a body count. Methadone and buprenorphine are evidence-based medications with the strongest survival outcomes of any treatment approach for opioid use disorder, and withholding them on ideological grounds is a decision that costs measurable, preventable lives. A 2019 study in JAMA Psychiatry found that buprenorphine and methadone reduced overdose mortality by 50% or more compared to no medication or behavioral treatment alone. The World Health Organization lists both methadone and buprenorphine on its essential medicines list, among the most critical medications available globally. Insulin for a diabetic modulates a physiological imbalance and requires ongoing, indefinite use. No one describes that as substituting one chemical dependency for another, because the framing would be absurd. 12-step-based residential programs that prohibit medication use among their residents show significantly lower retention and higher relapse rates than programs that incorporate medication. Many patients stabilized on buprenorphine or methadone hold jobs, raise families, and live functionally indistinguishable from people without a substance use disorder, which is the definition of successful medical management of a chronic condition. By the substitution logic, an HIV patient on antiretrovirals is just substituting one chemical dependency for the virus. The medication is working. That is what working looks like. The ideology that refuses effective medicine has a confirmed body count. 20. You've been told that crack cocaine and powder cocaine are fundamentally different substances. Different enough that U.S. federal law mandated sentencing disparities of 100 to 1 for decades, treating possession of 1 gram of crack as equivalent to possession of 100 grams of powder for mandatory minimum purposes. They are the same drug in different forms. The sentencing disparity had no pharmacological basis. It had an extensively documented racial one. Crack cocaine is powder cocaine that has been processed with baking soda and water to create a smokable form. Chemically, they are both cocaine. The primary pharmacological difference is route of administration. Crack is smoked, reaching the brain faster and producing a shorter, more intense effect. These are not the characteristics of a fundamentally different substance. They are the characteristics of a different delivery mechanism for the identical molecule. In 1986, when the disparity was enacted, crack was primarily associated with black urban communities. Powder cocaine was primarily associated with white users. The Sentencing Commission, the American Bar Association, and the American Civil Liberties Union all concluded that the disparity lacked scientific justification and produced racially discriminatory outcomes in practice. The Fair Sentencing Act of 2010 reduced but did not eliminate the disparity. The government sentenced people to decades in federal prison based on which route the same drug entered the same body. The pharmacology was identical. The zip codes of the users were not. That was always the entire point of the distinction, and it was never a scientific one. 21. You've been told that psilocybin mushrooms are physically toxic, that their Schedule I classification implies direct, significant danger to organs and bodily systems, the way truly toxic substances damage the liver, kidneys, and cardiovascular system. Psilocybin mushrooms have one of the lowest toxicity profiles of any psychoactive substance that has been studied in clinical settings. Physical organ toxicity at typical doses is, by the available evidence, essentially non-existent. Psilocybin's lethal dose in animal studies requires quantities thousands of times higher than any typical human experience, and there are no known confirmed human deaths attributable to psilocybin toxicity alone in the medical literature. The major documented risks of psilocybin mushrooms are psychological, acute panic, impaired judgment while impaired, and mycological, meaning people misidentify toxic lookalike species when foraging. The mushroom itself is not the primary danger. Getting the wrong mushroom is. a 2016 global drug survey of over 12,000 people who reported using psilocybin mushrooms found them to be among the safest recreational substances by emergency room presentation rate, lower than alcohol, tobacco, cocaine, MDMA, and cannabis. The Beckley Foundation, Johns Hopkins, and NYU research groups have all conducted psilocybin trials with explicit safety monitoring and recorded no serious adverse physiological events in screened participants. Psilocybin does not activate the dopamine reward pathway the way addictive substances do, and users do not characteristically escalate their use over time. The substance your government classifies as maximally dangerous with zero medical value is being administered to people with terminal cancer diagnoses at Johns Hopkins. The scheduling system is not a toxicology report. 22. You've been told that fentanyl is so potent that simply touching it, brushing against residue on a surface, handling a package, skin contact with contaminated material, can cause an immediate overdose. This narrative has circulated extensively in media, law enforcement training materials, and community warnings, and it has caused direct, preventable harm by making first responders afraid to administer help. Fentanyl cannot cause overdose through brief, incidental skin contact. The pharmacokinetics of dermal absorption make this impossible at the concentrations encountered in any realistic law enforcement or bystander scenario. Fentanyl transdermal patches, which are specifically engineered and designed to deliver the drug through skin, take 12 to 24 hours to reach therapeutic plasma levels, even in direct, sustained, adhesive contact with skin. Brief, incidental contact with residue cannot replicate the conditions required for meaningful absorption. A 2017 white paper from the American College of Medical Toxicology and the American Academy of Clinical Toxicology stated explicitly that the scenario of overdose from incidental fentanyl skin contact is extremely unlikely. The symptoms reported by first responders in alleged exposure incidents are consistent with anxiety-induced hyperventilation and nocebo effects, the documented psychological experience of harm from believed exposure. The myth has significant consequences. It has been used to justify law enforcement refusing to administer naloxone at overdose scenes out of self-protection concerns, resulting in preventable deaths while a reversible overdose went untreated. If fentanyl caused overdose from skin contact at ambient concentrations, pharmaceutical manufacturing workers could not handle it. The pharmacology is fiction. In this case, the fiction kills people. 23. You've been told that substance use disorders are fundamentally concentrated in poor, uneducated communities. That addiction is something that happens in specific zip codes to specific demographics, and that understanding it requires looking at the neighborhoods where it is most visible. The visibility difference is about healthcare access and legal exposure, not use rates. SAMHSA surveys consistently show that drug use rates are not significantly lower in higher income demographics. Wealthy people have access to private treatment, competent legal defense, and systems that insulate them from public and legal consequence. The first wave of the opioid epidemic, the prescription drug wave, began in predominantly white, rural, and suburban communities, not in the urban low-income areas addiction is most associated with in popular imagery. Alcohol. Use disorder has a documented relationship with income that runs contrary to the stereotype in some measures. Higher income correlates with higher rates of drinking, though not necessarily with higher rates of the most severe disorder. Cocaine, historically an expensive drug, has always had a significant upper-class user base. The powder cocaine and crack cocaine sentencing disparity discussed earlier reflects exactly this demographic split. The legal and public health systems process addiction very differently based on resources. Wealthy users access private treatment facilities with high thread count sheets. Poor users access the criminal justice system with mandatory minimums. This produces the statistical illusion that addiction is concentrated where it is most aggressively punished. The poor do not use more drugs. they have fewer ways to make the consequences disappear. What you are looking at when you see addiction concentrated in low-income communities is not a map of drug use. It is a map of consequences. 24. You've been told that DARE, Drug Abuse Resistance Education, was one of the most visible and effective youth drug prevention programs in American history. A landmark public health investment that kept a generation safer. Multiple independent, peer-reviewed evaluations found DARE to be ineffective at reducing drug use. Some studies found it slightly increased curiosity about the substances it described. Congress continued funding it for years after the evidence was fully in, which tells you something about who drug policy is designed to serve. A 2003 Government Accountability Office report reviewed 6 long-term evaluations of DARE and found no significant differences in illicit drug use between students who received the program and those who did not. The Surgeon General's Office, the National Academy of Sciences, and the GAO all independently reached the same conclusion. The program did not work. The American Psychological Association classified DARE as an ineffective primary prevention program. Research suggested that DARE's approach, providing detailed, specific information about drugs while urging refusal, may have inadvertently increased familiarity and curiosity, producing the opposite of its intended effect in some populations. Despite this evidence, the program received over $1 billion in federal funding before reforms, and continues in a modified form called Keeping It Real, with still contested evidence of meaningful effectiveness. The most famous anti-drug program in American history was evaluated by every credible scientific body that examined it and found it did not work. It was funded for decades afterward. This is not a drug policy story. It is a political theater story where the set never came down and the audience kept buying tickets. 25. You've been told that naltrexone, an opioid receptor blocker approved for both opioid and alcohol use disorder, is a last resort medication, something reserved for people who have hit the absolute bottom of their disease trajectory and exhausted every other option. This framing keeps a proven medication away from people who could benefit from it earlier, when the window for effective intervention is far wider than the treatment system pretends. Naltrexone can be used at early stages of problematic alcohol use, and the evidence for its effectiveness in reducing heavy drinking is substantial, even in people who would not meet the clinical threshold for severe disorder. The Sinclair method uses naltrexone in combination with continued drinking to gradually extinguish the reward response to alcohol. A pharmacologically sound, and for many patients, highly effective approach that is fundamentally different from traditional abstinence-first models. A 2014 meta-analysis in JAMA found naltrexone reduced heavy drinking days and increased abstinence rates significantly compared to placebo. Naltrexone has been FDA approved for alcohol use disorder since 1994 and is available as both a daily pill and a monthly injectable called Vivitrol. Yet physician prescription rates remain low due to stigma and inadequate training. Unlike medications for opioid use disorder, naltrexone has essentially no abuse potential because it produces zero euphoria. A 2006 study found that naltrexone combined with basic medical management produced outcomes comparable to far more resource-intensive and expensive treatments. A medication that has worked for 30 years is being withheld from people because suffering should apparently reach a certain floor before effective help arrives. 26. You've been told that mixing alcohol with energy drinks is basically the same as mixing alcohol with any other beverage. A convenience, a preference, roughly the same risk profile as a beer and a soda. The caffeine in energy drinks does not cancel out alcohol. It masks the sensory experience of intoxication in a specific and dangerous way, causing people to consume significantly more alcohol than their body's own warning signals would otherwise permit. The FDA banned pre-mixed caffeinated alcoholic beverages in 2010, finding the combination was unsafe. An extraordinarily rare regulatory intervention for an alcohol product, reflecting how significant the concern was. Studies conducted before the ban showed that people drinking caffeinated alcoholic beverages consumed significantly more alcohol per session than those drinking alcohol alone, because the caffeine suppressed the fatigue and sedation that would normally signal the brain to slow down. Caffeine does not reduce blood alcohol concentration. It does not improve driving ability. It does not accelerate liver processing of ethanol in any meaningful way. It reduces your awareness of how impaired you actually are while doing nothing about the impairment itself. Emergency room visit rates and alcohol poisoning rates were significantly higher among caffeinated alcoholic beverage consumers in pre-ban studies. The original marketing for several of these products explicitly targeted underage drinkers, and the combination's ability to mask intoxication was noted as a feature in some internal company materials. Caffeine does not make you less drunk. It makes you less aware of how drunk you are. The combination does not reduce the poison level. It disables the warning light while the poison level keeps climbing. 27. You've been told that psychedelics belong to the cultural category of fringe substances, counterculture artifacts, things for people who opted out of productive society, irrelevant to serious medicine, serious science, or serious anything. Psychedelics were mainstream psychiatric research tools in the 1950s and early 1960s, used by respected scientists at major academic institutions with published results in peer-reviewed journals, before a political decision, not a scientific one, ended the research. Between 1950 and 1965, over 1,000 peer-reviewed papers were published on the therapeutic use of LSD, covering over 40,000 patients across multiple clinical populations. The U.S. government's own research programs, including the CIA's MKUltra, extensively studied LSD, not as a fringe curiosity, but as a potentially powerful tool for behavior and cognition, which is a profoundly different framing than the counterculture narrative. Humphrey Osmond, the psychiatrist who coined the word psychedelic, conducted research on LSD for alcoholism treatment at a Canadian hospital in the 1950s, with results that hold up comparably against current best practices for the condition. The Nixon administration's placement of psychedelics on Schedule I share in 1970 was explicitly described by Nixon aide John Ehrlichman in a 1994 interview, published in Harper's Magazine in 2016, as a political tool targeting anti-war leftists and black communities. As of 2024, active psychedelic research centers operate at Johns Hopkins, NYU, UCSF, and Imperial College London. The research came back to the same hospitals with the same findings. The 50-year gap between them was a political detour, not a scientific conclusion. 28, you've been told, or you have assumed, that fentanyl can be identified by looking at it. That if the pill looks right, the powder looks correct, the color matches what you have seen before, it is probably what you think it is. Fentanyl is pharmacologically active at microgram level doses, is colorless and odorless, and is completely undetectable through any form of sensory examination. Counterfeit pills are pressed with industrial equipment that produces tablets visually and tactilely indistinguishable from legitimate pharmaceutical products, including accurate-appearing stamps, colors, and imprinted codes. Fentanyl's active dose is approximately 2 milligrams, a quantity equivalent to a few grains of salt, making it invisible as a contaminant in any powder or pressed pill. DEA laboratory testing found that in 2022, approximately 6 out of 10 counterfeit pills containing fentanyl had enough fentanyl in a single pill to be lethal to a non-tolerant person. Fentanyl test strips can identify its presence in solution, but cannot quantify concentration, cannot detect all fentanyl analogs, and cannot tell you whether the dose is survivable. The contamination problem extends beyond opioids. Fentanyl has been detected in methamphetamine, cocaine, and MDMA supplies, meaning it is reaching people with no opioid tolerance who had no reason to believe opioids were involved. You cannot see a lethal dose of fentanyl with the naked eye. The amount that kills a non-tolerant person is smaller than what you would lose blowing your nose. The idea that visual inspection functions as a safety measure is a comfort mechanism. It is not pharmacology, and treating it as one has consequences. 29. You've been told that caffeine gets a pass, that it is not a real drug, not in any meaningful sense, that calling it a drug is either pedantic or ridiculous, and that the universal morning ritual of consuming it before being fit for human interaction is simply a preference, not a pharmacological dependency. Caffeine is a pharmacologically active substance with a documented mechanism of action, a recognized dependence syndrome, a clinically validated withdrawal syndrome, and an established toxic dose that has caused confirmed deaths. Caffeine works by blocking adenosine receptors in the brain, a specific, well-understood pharmacological mechanism that produces its stimulant effects. Caffeine use disorder and caffeine withdrawal are both recognized conditions in the DSM-5. Caffeine withdrawal produces headaches, fatigue, irritability, and impaired concentration in regular users who abruptly stop, symptoms that follow the standard pattern of substance withdrawal recognized across all other drug classes. Caffeine has a documented lethal dose of approximately 10 grams, equivalent to roughly 75 to 100 cups of coffee at typical concentrations. Highly concentrated caffeine powder and supplement products have caused documented deaths of young people, leading the FDA to take the unusual step of regulatory action against products legally sold as dietary supplements. The difference between caffeine and the substances your society labels dangerous is not pharmacological. It is social. The morning ritual has a withdrawal syndrome, a lethal dose, and confirmed fatalities. You probably had some before reading this, and will have more tomorrow. The pharmacology of your morning is identical to the pharmacology of addiction. Only the cultural framing is different. 30. You've been told that detox is the treatment, that getting someone medically through withdrawal and clearing the substance from their system is the intervention, the milestone, the moment where the problem is addressed. Detox is not addiction treatment. It is withdrawal management. The relapse rate after detox-only care is so high, it is essentially the statistical default outcome without follow-up, and the period immediately after detox carries some of the highest overdose mortality of any point in the disease trajectory. NIDA explicitly states that detoxification alone is not an effective treatment for addiction and must be followed by evidence-based ongoing care. Studies show that the majority of patients who complete opioid detox without follow-up medication or therapy relapse within 30 days, with the dramatically reduced tolerance that detox produces, making each relapse more likely to be fatal than any prior episode. The insurance and treatment industry's historical preference for funding short-term detox episodes over long-term treatment is driven by cost structure, not clinical evidence. Repeated cycles of detox and relapse, called the revolving door in clinical literature, are more the norm than the exception in non-comprehensive treatment models. The neurobiological changes that constitute addiction, alterations in reward circuitry, stress response systems, and executive function are not resolved by physically clearing a substance from the bloodstream. They require time, often months to years, and ongoing clinical intervention to begin normalizing. Detox is removing water from a flooded basement without fixing the broken pipe. The basement looks better for a week. The water comes back. The pipe was always the actual problem, and treating only the flood without addressing it is not a solution. 31. You've been told that comparing cannabis across generations is reasonable, that your older relative's cannabis experience from the 1970s is pharmacologically comparable to what is widely available today, and that safety arguments made about one apply equally to the other. The substance commonly available today is pharmacologically very different from what was used in previous decades, and the potency shift has real, documented clinical implications. Studies of cannabis samples from DEA seizures show average THC content rose from approximately 4% in the 1990s to over 12% by 2014, with many commercially available products reaching 25 to 30% or higher in states with legal markets. Concentrates and extracts, commonly called dabs, wax, or shatter, can contain 60 to 90% THC, a product category that did not exist in any previous generation's cannabis landscape. Higher THC concentrations are associated with increased rates of cannabis use disorder, more severe acute anxiety and psychosis reactions, and greater potential impact on developing adolescent brains that are still forming. CBD, the non-psychoactive cannabinoid that may modulate some of THC's adverse effects, has been selectively bred out of many commercial strains in favor of maximizing THC content, removing a naturally occurring partial buffer. Research conducted on lower potency historical cannabis is not directly applicable to the pharmacological reality of current high-potency products, which means much of the legacy safety data is being used to justify claims about a substantially different substance. Comparing 1970s cannabis to current concentrates using identical safety logic is like using light beer safety data to evaluate grain alcohol. The category is the same. The dose is not, and dose is everything. 32. You've been told that ibogaine is a Schedule I substance with no accepted medical use, which in popular shorthand means recreational drug with no legitimate purpose, filed alongside everything else in the dangerous and pointless category. Ibogaine interrupts opioid and stimulant withdrawal in a way no currently approved medication can replicate, has been used in clinical settings internationally for decades, and produces outcomes that have attracted the attention of the U.S. Navy, the FDA, and multiple major research institutions. Ibogaine appears to reset opioid receptor sensitivity and modulate dopamine pathways in a way that dramatically reduces or eliminates withdrawal symptoms for 12 to 36 hours following a single treatment session, a mechanism that has no parallel in any approved pharmaceutical. Multiple observational studies from licensed clinics in Mexico, Canada, and Europe document significant reductions in opioid use following ibogaine treatment, with some patients reporting elimination of cravings for months or years afterward. The U.S. Navy funded research on ibogaine's addiction treatment potential in the 1990s before political pressure ended the program. The primary documented medical risk is cardiac arrhythmia. Ibogaine prolongs the QT interval and has caused deaths in people with pre-existing cardiac conditions who received it without medical screening, which is precisely why controlled clinical research is more urgent, not less. The FDA granted breakthrough therapy designation in 2024 for a synthetic ibogaine derivative for opioid use disorder, acknowledging therapeutic potential after decades of Schedule I classification actively blocking the research. The drug that could interrupt opioid withdrawal in a single session was illegal to research in the United States, while the opioid epidemic was killing hundreds of thousands. That was not a safety decision. It was a scheduling decision, and the difference matters enormously. 33. You've been told that antidepressants are addictive. Patients say it, families say it, and occasionally clinicians say it without precision. People describe being hooked on their SSRIs, unable to stop, dependent on a pill just to function. The clarification here matters clinically because conflating two different phenomena produces two different harms. Antidepressants do not produce addiction in the pharmacological sense. Addiction requires compulsive use, despite harm and loss of control over intake. Antidepressant users do not compulsively escalate doses, do not experience euphoria, and do not seek them for psychoactive recreational effects. What many long-term antidepressant users do experience is physiological dependence. An antidepressant discontinuation syndrome is real, clinically significant, and frequently underestimated by prescribers who initiate these medications without adequate planning for eventual discontinuation. Discontinuation syndrome occurs in approximately 20 to 50% of long-term users who stop abruptly and includes dizziness, brain zaps, nausea, irritability, and in many cases a return of depressive symptoms. Paroxetine, sold as Paxil, has the most clinically significant discontinuation syndrome of the commonly prescribed SSRIs, and some clinicians describe it as among the more demanding medications to successfully taper. The distinction matters because addiction stigma prevents people who would genuinely benefit from antidepressants from taking them, while the reassurance that there is no dependence leads prescribers to underestimate the difficulty of stopping and skip the taper plan that would make it manageable. Being unable to stop beta blockers without rebound hypertension does not make beta blockers addictive. Being unable to stop SSRIs without brain zaps does not make SSRIs addictive either. The correct word is dependence. The correct clinical response is a gradual taper and an honest conversation before the prescription is written. 34. You've been told that the legal framework for controlled substances carries scientific legitimacy, that the schedule of a drug reflects a rational, evidence-based assessment of its relative harm and medical utility, conducted by experts using pharmacological data to place substances appropriately. The original scheduling decisions were driven overwhelmingly by political, racial, and economic considerations, and the man most responsible for designing the system said so himself on the record. Nixon aide John Ehrlichman stated explicitly in a 1994 interview, published in Harper's Magazine in 2016, "We knew we couldn't make it illegal to be either against the war or black, but by getting the public to associate the hippies with marijuana and blacks with heroin, and then criminalizing both heavily, we could disrupt those communities." Cannabis prohibition at the federal level in 1937 was significantly shaped by Harry Anslinger's campaign to build the Federal Bureau of Narcotics. The American Medical Association testified against the Marijuana Tax Act that year. Schedule I classification, representing maximum restriction and no accepted medical use, was applied to cannabis and psychedelics despite prior medical use and active clinical research. Heroin is Schedule Y, while cocaine is Schedule II. Cocaine being considered to have accepted medical uses, an inconsistency with no clear pharmacological logic when both are highly addictive. Alcohol and tobacco, responsible for more deaths than all illegal drugs combined, were never scheduled at any level. The scheduling system is not a toxicology report. It is a historical record of which communities were politically targeted, during which administrations assigned a scientific-sounding name and then treated as settled pharmacology for half a century. 35. You've been told to worry about secondhand cannabis smoke, that being in a room where cannabis is smoked will produce intoxication, or more practically, that passive exposure will generate a positive drug test and cost someone a job or custody arrangement they cannot afford to lose. Under realistic exposure conditions, passive cannabis smoke does not produce intoxication or positive drug tests in non-users. The scenarios required to produce either outcome are essentially laboratory constructs with no real-world parallel. A 2015 study published in the Journal of Analytical Toxicology placed non-smoking participants in a room with active cannabis smokers under deliberately enclosed conditions. And even in that extreme scenario, only one participant produced a barely positive result at the absolute lowest detection threshold, using the most sensitive testing available. Under realistic conditions involving any ventilation, any distance, or any normal indoor environment, passive exposure does not produce THC blood or urine levels sufficient to trigger standard workplace drug tests. Workplace drug tests use cutoff levels specifically calibrated to prevent passive exposure false positives. This is a feature of the test design, not an accident. Studies that showed detectable THC from passive exposure involved deliberately extreme conditions, sealed, unventilated rooms with multiple simultaneous smokers, designed specifically to maximize exposure beyond any real-world scenario. The contact high from secondhand cannabis smoke is a cultural construct. If sitting in a room with cannabis smoke were enough to fail a drug test, Amsterdam's tourism infrastructure would have noticed. The exposure level required is, in practical terms, actively trying to get intoxicated without actually smoking anything. 36. You've been told that treatment does not work, that people just relapse anyway, that rehab is a revolving door, that addiction is essentially permanent regardless of intervention, and that investing in treatment is an exercise in futility. This narrative is widespread in public discourse, in families, and destructively among people with substance use disorders themselves, where it functions as a reason to not seek help. Substance use disorders have treatment outcomes that are directly comparable to other recognized chronic medical conditions. Relapse rates for substance use disorders of 40 to 60% are comparable to relapse rates for hypertension of 50 to 70% and asthma of 50 to 70%. No one describes hypertension as untreatable because patients sometimes have their blood pressure spike again. The key variable in addiction treatment outcomes is duration and comprehensiveness of care. Longer engagement with treatment produces significantly better outcomes, yet insurance systems have historically funded extremely short treatment episodes, sometimes as brief as 3 to 7 days, that the clinical literature has never supported as adequate. Medication-assisted treatment dramatically improves outcomes specifically for opioid use disorder, reducing mortality and sustained use in ways that behavioral treatment alone cannot replicate. Multiple longitudinal studies show that people in long-term recovery, over 5 years of sustained remission, are found at rates exceeding 50% when populations are followed carefully over time. Relapse, in the medical model, is a clinical signal that the treatment plan needs adjustment, the same way uncontrolled blood pressure signals a medication change. No one calls a blood pressure spike proof that cardiology is futile. The standard applied to addiction is uniquely punishing, and it conveniently justifies underfunding effective care. 37. You've been told that rock bottom is real, that a person must reach the absolute lowest point of their life before they can genuinely commit to getting better, and that intervening before that point arrives is not just premature, but counterproductive. There is no scientific evidence for the rock bottom concept. It is a narrative construct. It emerged from storytelling rather than clinical research, and waiting for it actively allows preventable harm, medical deterioration, and death to accumulate, while everyone waits for a threshold that has no defined location. The concept emerged from 12-step tradition and cultural storytelling about recovery, not from clinical research on what actually predicts treatment, readiness, or treatment success. Research on motivational interviewing and treatment engagement shows that individuals at many different levels of problem severity can engage successfully with treatment. Readiness is not a fixed threshold requiring a specific catastrophe to unlock. Early intervention in substance use disorders, before severe consequences have accumulated, consistently produces better outcomes in the research literature, identical to early intervention in any other medical condition. The framework that a bottom must be reached has been used to justify withholding treatment, housing, and harm reduction services from people assessed as not ready, a clinical position with no supporting research. Waiting for rock bottom often means waiting for overdose, incarceration, or severe organ damage, each of which dramatically complicates treatment and recovery trajectories. No cardiologist waits for a full heart attack before discussing risk reduction with a patient. The idea that someone must lose everything before they deserve help is not a clinical framework. It is a cruelty that has been assigned a philosophy, and the philosophy has been doing real damage for decades. 38. You've been told that cannabis produces permanent motivational deficits, that regular use creates a lasting clinical syndrome of apathy and inability to pursue long-term goals, even between use episodes when the drug is not actively in the system. This was formalized into a clinical concept called amotivational syndrome, and researchers have spent decades looking for it as a distinct, pharmacologically produced condition. They have not consistently found it. A 2006 review in Psychopharmacology found no evidence of a specific amotivational syndrome caused by cannabis that was distinct from the general effects of acute intoxication during use. Motivation deficits observed in heavy cannabis users overlap substantially with symptoms of depression and other mental health conditions that frequently precede or co-occur with heavy use, making causality extremely difficult to establish in either direction. Acute THC intoxication does impair motivation and reward processing during the intoxicated state. This is a well-documented within-session effect. The contested scientific claim is that it persists in measurable form during periods of sobriety, and the evidence for that specific claim in otherwise healthy adults is weak and inconsistent. Regular heavy cannabis users do show differences in dopamine system function on neuroimaging, but whether cannabis caused those differences or whether pre-existing differences predict heavy cannabis use remains scientifically unresolved and actively debated. Many of the studies showing motivation deficits do not adequately control for socioeconomic factors, concurrent mental health conditions, or the fundamental confound that people with low motivation may simply use cannabis more heavily. The stereotype selectively edits its evidence. The pharmacology is considerably more complicated than the couch. 39. You've been told that giving a child stimulant medication for ADHD creates a pathway to substance use, that medicating a young brain with a stimulant is priming it for addiction, creating a chemical familiarity that will express itself later as a problem. The evidence points in the opposite direction with unusual consistency. Untreated ADHD is a significantly stronger predictor of substance use disorder than ADHD treatment with stimulant medication, and the biological reason for this makes straightforward pharmacological sense. A 2003 meta-analysis in pediatrics by Wylans and colleagues found that stimulant treatment of ADHD in childhood was associated with approximately a 50% reduction in risk for subsequent substance use disorders compared to untreated ADHD. The neurobiological risk factor for substance use in ADHD is the underlying dopamine dysregulation that characterizes the condition. Stimulant medication helps address that dysregulation, rather than amplifying or entrenching it. Multiple longitudinal studies following both treated and untreated ADHD populations show consistently lower substance use disorder rates in the treated group over time. ADHD itself, characterized by impulsivity, risk-seeking behavior, difficulty registering future consequences, and reward dysregulation, is a significant independent risk factor for substance use disorder, entirely separate from any medication effect. The medications used for ADHD, when taken as prescribed orally at therapeutic doses, produce substantially slower dopamine changes than the same chemical compounds used recreationally through alternative routes. The abuse potential is a function of dose and route, not pharmacology at the clinical level. The fear that treating a brain condition creates the problem the brain condition was already producing is backwards pharmacology. Not treating ADHD was always the gateway. 40. You've been told that combining substances adds risk in a roughly additive way, that mixing alcohol with something else is just turning up the same risk dial, not creating a fundamentally different pharmacological situation. Several drug-alcohol combinations produce synergistic effects that are dramatically more dangerous than either substance alone could produce at the same doses taken independently. Alcohol and opioids both depress the central nervous system and the respiratory drive. Combined, they suppress breathing at doses that would likely be survivable with either substance alone, and this combination is implicated in a substantial proportion of opioid overdose deaths. Alcohol and benzodiazepines act on overlapping receptor systems and produce dramatic synergistic CNS depression. This combination is one of the most clinically dangerous, commonly occurring polysubstance scenarios, with each substance multiplying rather than adding the respiratory depressant effect of the other. Cocaethylene is a metabolite produced exclusively when cocaine and alcohol are present in the body simultaneously. It is more cardiotoxic than either cocaine or alcohol alone, and extends the duration of cocaine's cardiovascular effects, creating a distinct molecule and a distinct risk that neither substance produces independently. Alcohol combined with acetaminophen at doses that would be individually safe increases liver toxicity risks substantially, particularly with chronic alcohol use. A combination that occurs constantly because both are freely available, and people do not think of acetaminophen as a drug interaction risk. MDMA combined with stimulants, alcohol, and sustained physical exertion creates a dangerous scenario of hyperthermia, dehydration, and cardiovascular stress, where the combination and context matter more than any single substance. The math of combining certain substances is not additive. It creates new chemistry in your body that did not exist before. That is not the same equation. 41. You've been told that widespread psychoactive substance use is a modern phenomenon, a product of industrial chemistry, urban alienation, or some particular failure of contemporary civilization, and that ancient or indigenous use of mind-altering substances was a limited, peripheral behavior practiced by a small fraction of ancient populations for narrowly ritual purposes. Deliberate psychoactive substance use is one of the most universal and ancient human behaviors in the documented historical and archaeological record. Every inhabited continent, across every era of recorded history, shows evidence of it. Archaeological evidence of poppy cultivation, the source of opium, dates to at least 3,400 BCE in Lower Mesopotamia. Cannabis residue has been identified in burial sites in China dating to approximately 2,500 BCE, and evidence of cannabis use in ancient Egypt, India, and the Middle East spans multiple millennia of documented history. Coca leaves have been chewed for their stimulant effect in South America for at least 8,000 years, evidenced by dental analysis and plant material found at Peruvian archaeological sites. The ancient Greek oracle at Delphi is now hypothesized by archaeologists to have been influenced by naturally occurring ethylene gas rising through fissures in the chamber floor. A built-in geologically provided psychoactive environment that may have shaped one of history's most influential religious institutions. Alcohol's production predates written history. The oldest known written recipe, Sumerian and dating to approximately 1800 BCE, is for beer, and fermentation evidence from archaeological sites predates that by thousands of years. Humans have been deliberately altering consciousness since before the first city, the first written record, and the first organized religion. The idea that this is a modern failure is about 10,000 years behind the actual timeline of human behavior. 42. You've been told that serious intoxication is visible, that someone in danger from a substance will display obvious behavioral signals, and that if someone appears okay, they probably are. Several intoxication states are either essentially invisible or actively misleading to visual inspection, and some of the most dangerous phases of overdose and poisoning are the ones that most convincingly resemble ordinary unconsciousness. Blood alcohol concentration continues rising after drinking stops. Someone who appears relatively coherent when they stop consuming alcohol may reach a dangerous or lethal BAC in the following hour as absorption continues. Alcohol poisoning frequently presents as someone sleeping it off. The person appears to be simply unconscious when they are actually in a state requiring medical monitoring and intervention. Stimulant intoxication, cocaine, methamphetamine, can produce someone who appears alert, articulate, and entirely functional, while simultaneously experiencing dangerous cardiovascular stress. Heart attacks and strokes occur in people who appeared completely fine minutes before the event. Benzodiazepine intoxication can produce someone who appears simply sleepy while experiencing significant respiratory depression, particularly in combination with alcohol or opioids, where the combined effect exceeds what visual assessment could ever reveal. GHB is pharmacologically distinctive in this regard. It has a narrow therapeutic to toxic window, and a person can transition from alert and conversational to unconscious with almost no visible intermediate stage, and the drug is colorless and odorless. The body does not display a warning sign when the situation becomes dangerous. Deciding someone is fine because they look fine has been the final assessment made of many people who were not fine at all, and looking fine was not evidence of anything except appearance. 43. You've been told that the war on drugs, launched formally under Nixon in 1971 and massively escalated through subsequent administrations, was a policy designed to reduce drug use, drug availability, and drug-related harm evaluated on those terms. By virtually every measurable metric, drug use rates, overdose deaths, and drug availability have not improved since the war on drugs began. The United States has spent an estimated $1 trillion on this effort since 1971. Drug overdose deaths in the U.S. exceeded 100,000 per year as of 2022, a historic high recorded 50 years into the initiative. Drug seizures and interdiction have not reduced supply in any sustained, measurable way. The price of most illicit drugs has decreased over the past 40 years, while purity has increased, which is precisely the opposite of what successful supply reduction would produce. The United States has the highest incarceration rate in the world, with drug offenses as a major driver, and simultaneously maintains among the highest rates of drug use and overdose mortality among developed nations. The inverse of what the deterrence model predicts. Countries that shifted toward public health frameworks, Portugal, Switzerland, Iceland, have seen significant reductions in drug-related mortality and disease transmission without the predicted increases in use. The war on drugs has been disproportionately enforced against Black and Latino communities, despite consistent survey data showing similar drug use rates across racial groups. When a strategy has consumed $1 trillion over 50 years, produced outcomes opposite to its stated goals, and disproportionately harmed the specific communities its architects intended to target, the charitable interpretation is failure. The uncharitable one is that it succeeded at something other than what was advertised. 44, you've been told, and many people in recovery communities and healthcare settings believe that someone with a history of substance use disorder should never receive opioid pain medication under any circumstances. Not for surgery recovery, not for acute trauma, not for terminal illness, because the risk of relapse is treated as categorical and absolute, regardless of the clinical situation, the available alternatives, or what evidence-based medicine actually recommends. This blanket prohibition has caused documented harm by denying effective pain management to people in recovery, and the clinical evidence does not support categorical opioid avoidance across all medical contexts. ASAM guidelines state that with appropriate precautions, careful monitoring, and time-limited use, opioid analgesics can be used in patients with opioid use disorder for acute pain management, particularly in post-surgical or trauma contexts where alternatives are insufficient. Undertreated acute pain is itself a documented relapse risk factor. Pain is a known trigger for substance use, and leaving it untreated is not the conservative or protective option it is presented to be. It is an active clinical risk in the other direction. Patients with opioid use disorder who are stable on buprenorphine should have their buprenorphine continued during acute pain management periods, with additional short-acting opioids added if necessary, rather than having their maintenance medication discontinued. The categorical no opioids ever approach has produced documented cases of people in recovery undergoing major surgical procedures without adequate analgesia, and people being denied palliative opioids during terminal illness. Telling someone in cancer treatment that their recovery history disqualifies them from pain management is not protecting them from addiction. It is punishing them for their medical history with suffering. The disease model was supposed to produce better medicine, not a new reason to withhold it. If you want to see more, click the video on screen now.